Ladies and gentlemen, we'd like to begin the afternoon session number 3. Session number 3, as you recall, in the morning session, we have been identifying the various challenges of healthcare system in Japan. And so, having heard that discussion, we will now think about the future. How can we conduct the appropriate and necessary structural reform? So we'd like to have a discussion on the future possibilities. And now it is the summer bug jumping into fire. Under the new DPJ administration, the senior leader for policy, Mr. Seiji Maehara, has joined us. Chairman of the Policy Research Committee has joined us. He'll be talking about his policy statement in terms of healthcare system. And in ensuring the implementation of such policies, we hope that he makes important policy decisions. So, Mr. Maehara, please.
Ladies and gentlemen, dear friends, good afternoon. Am I a fly jumping into the fire? Well, it is indeed a great pleasure to see the grand holding of this symposium commemorating the launch of a Lancet special issue on Japan. I heartily offer my congratulations to you all. Mr. Yamamoto of JCIE and other parliamentarians beyond the party lines are dedicating themselves for enhanced international exchange. I'm a part of it. And Mr. Takemi, since he was a parliamentarian, since we belong to the Parliamentarians League, I used to have discuss diplomatic matters. His father used to be the president of JMA, and he was also the senior parliamentary vice minister for the health, welfare, and labor. I know that I enjoyed discussing with him. I have enjoyed non-partisan discussion. We also have Mr. Yamada, who is the governor of Kyoto Prefecture, who happens to be the chairman of the National Governors Association. So in the presence of all these important people, I have a pleasure of making my remarks. 2 points I wish to convey to you. One is the demography. As a demographic change occurs in Japan regarding the healthcare system in Japan, going forward, there will be incessant reviews which are required for improving the health care system. Of course, the current state is such that the natural increase requires 1 trillion yen in terms of health care. But in addition to the natural increase, there has to be an exact review which is required from the budgetary aspect. I served as the minister for MLIT, the Ministry for Land, Infrastructure and Transport, and at that time, together with Mr. Nagatsuma, we realized that there is a situation where hospital is turning into a place for elderly people to die. So we thought that hospitals are turning into the residence for the elderly people. Consequently, it is adding to the medical cost for the Japanese people. We have to remedy that situation. We changed the law together with Mr. Nagatsuma. We changed the law, and in current budget, 33 billion yen is spent for creating the elderly-only housing projects with care. That program is making some strides. So in that sense, all kinds of variety of reviews will have to be made in terms of free access and universal insurance coverage. That is something that has to be debated going continuously. We need your advice. Last point, second point. This point is exactly something related with the works of Mr. Yamamoto and Mr. Takemi. When it comes to health care and health, we can't do anything unless we have an international cooperation. especially the measures against infectious diseases or measures against poverty. And because of the poverty, all kinds of sickness may arise. So we need international collaboration in countering these problems. So this is the cardinal problem in the field of human security. So the JCIE, Mr. Yamamoto, is taking the lead in this discussion. Mr. Takemi also is the leadership in this kind of discussion. I stand on the position of having responsibility for the ruling party's policy affairs. But going beyond the party lines, we will have to make our efforts to try to have the better healthcare system so that we can provide sense of security and safety to the minds of the Japanese people. You are having a free-flowing discussion. In the course of your discussion, I'd like to benefit from your wisdom and your suggestions. May I conclude my remarks by wishing for your further prosperity and developments in all your works in this field. I know that I am not in the program, but thank you very much for giving me this floor to speak. Thank you.
Well, the fly jumping into the fire was how I introduced him, but he prepared his remarks. Thank you very much for those kind words. So now I would like to open formally the session number 3. Moderator is Professor from Tokyo Women's Medical College, former editorial writer of Nikkei Shimbun, Professor Shusuke Watanabe. So please... over to you, Professor Watanabe. Thank you very much for the kind introduction. Mr. Hatajimi said that I am teaching now at Tokyo Women's Medical College. I'm not a physician. I have been working as an editorial writer 40 years in a Japanese newspaper company, and 30 years or more out of that I have been writing editorials on healthcare matters. So in the morning session, we talked about the Japanese healthcare system, the insurance system, and the delivery system. There are various advantages and strengths, and the life expectancy at birth and other outcome is remarkable, but also there have been various issues and challenges, and also against the backdrop of the disasters, such challenges have become manifesting. And so we identify the issues, and so in the afternoon we'd like to talk about the various reforms necessary to tackle those issues. That will be the focus of session number 3. As you see in the program, we'll be talking about maintaining equity, efficiency, and sustainability. So that's the subtitle for this session. For example, when we think about sustainability, conventionally the Ministry of Finance or at one time some government administration talked about sustainability of finance. They had never talked about the delivery system sustainability. So when we talk about reform in this session, as was mentioned in the morning session, we'd like to talk about the good system here in Japan, of course, with its challenges and issues, to overcome those issues, to sustain the good system of Japan in Japan as well as abroad. So we'd like to think about reforms in the general sense in this session number 3. So the first presentation will be given by Professor Ikegami from Keio University, who made a presentation in the morning, and also we will hear from 3 commentators. In terms of timing, I will give 15 minutes to Professor Ikegami. I would like to give 7 to 8 minutes each to the commentators. And if everything is scheduled, there'll be 30 minutes or so left for QA. So like in the morning, we'd like to open the floor or to have an active interaction with the audience during the Q&A session. So I solicit for your cooperation. So the first presentation will be given by Professor Naoki Ikegami of Keio University. Thank you very much. May I have my slide, please? The title is Reforms for the Future. The next slide, please. At the macro level, there's the aging of the society, there's continued slowdown of the economy and the stagnant economy. On the other hand, there's the increasing healthcare expenditure with the advances in medical technology and the higher prices of those technologies. So can expenditures be reduced by eliminating waste? That is a major challenge for us to address. But what can be considered as waste? For the patient, no aspect is a waste for them. If they have a headache continuously undergoing CT scan, we cannot call that a waste. So can healthcare costs be contained while maintaining quality? We talk about it a lot, but we need to restructure the overall healthcare delivery system and not focusing just on individual services and medications. Next slide, please. First of all, let us review the current status of human resources. The objective is to train and distribute human resources to match the needs that the citizens have. And the biggest challenge is accessible placement of human resources capable of providing comprehensive and continuous care to the elderly. However, training in medical schools, nursing schools, and major university hospitals mostly focus on specialized skills required for acute care. Overwhelming majority of physicians become specialists in different organs. Instead of becoming a general surgeon, they become specialists in surgery for the stomach or esophagus, for example. And almost no training is available to become generalists, and no training available to become visiting nurses. So no target number for training specialists reflecting the future needs. Most specialist societies, likewise, do not have such training plans. So the reform that we propose is to train human resources to reflect the needs and to place medical specialists based upon their skills and expertise, and focus funding to train generalists. And to do that, we need to start from training the instructors. The instructors to provide training for general practice. And setting up the national target number of specialists to be trained by each of the academic societies. And to be, of course, this would be determined from the number of instructors and the number of cases they would need to experience as well. And national government and the Japan Specialist Accreditation Organization to jointly adjust the number of physicians in each specialty. That is the necessary reform. Next slide talks about the current status of facilities. We have the so-called freedom to open practice system. Physicians are therefore allowed to practice anywhere at any time and proclaim any subspecialty. Hospitals basically are not allowed to increase number of beds, but can open any subspecialty department and purchase any kind of medical equipment. And this is not enough to assure quality. And how does the government control the situation? They control the flow of money by regulating medical service fees. If, for example, the fee schedule for services considered to be needed on a policy basis is set at a higher rate, and lower the fees for services considered excessive. For example, home care services is set relatively high, and expensive equipment-based diagnosis such as MRI is set at a relatively low fee. The government control has contained costs, but it is not enough to ensure quality. So the reform necessary for facilities is that selection and concentration of medical resources in line with community health plan has to be promoted. For cancer treatment, we need to specialize the hospital functions and concentrate patients, and priority on quality improvement over accessibility. That should be what is to be promoted in the area of oncology. And for emergency medical service, we need to develop accessible systematic triaging of critical and mild cases. In other words, the emergency medical service that is at the acute setting and the cancer treatment, which is rather elective, have to be differentiated and coped with different health plans. Community health plans were made mandatory to prefectural governors to develop over 25 years ago, and I'm really sorry to talk in front of the distinguished governor that it has not been functioning well. The fee schedule is decided at the national level. The insurance plans basically are divided into employee-based plans organized at the national level and community-based plans organized at the municipal level. Prefectural governors lack responsibility and authority in healthcare policy. So, first of all, let us think about the different insurance plans. The current health insurance, the premiums are, there is a complicated combination of the premiums with the taxes to secure the fund. There is a fragmentation of 3,500 insurance plans. All insurance plans, of course, want to keep their premiums low. The employee-based plans limit their enrollees to the relatively healthy and high-income full-time employees. And the premium increase for the citizens' health insurance covering the remaining population, as well as the increase in the number of uninsured. The growing budget deficit has made the increase in tax subsidies to help reduce the disparity between the insurance plans unsustainable. And the increase, on the other hand, in the percentage of elderlies in the total health expenditure is seen. And further increase needed in subsidies from taxes and contributions from health plans is recognized. So the reform we propose is as follows. Integration and reorganization of all plans at the prefectural level. The objective is that residents in a given prefecture with the same income will be paying the same premium regardless of age or occupation. Through such integration, the premium level of plans that enroll those with high average income will be raised, which enables the securing of the funding. The average premium for society-managed health insurance is currently half that of Germany. The role of the national government is to adjust disparities in income level and age distribution among prefectures. In this case, in other words, subsidizing prefectures with lower than average income level or greater percentage of middle-aged and elderly persons, and also introduce adjustment for major disasters. The role of the prefectural government, on the other hand, is to develop an optimal healthcare service system within the limits of premiums that the residents are willing to pay. Next. So, what is the impact and effect of consolidating health plans at the prefectural levels? Healthcare is a local industry. In other words, 90% of the demand is handled within the same prefecture. There are major differences in culture and distribution of medical facilities in each region. So nationally uniform regulation, for example, fee schedules to induce cost restriction are not conducive to making flexible change. This is like a steering of a large tanker. So left to municipalities, also it is difficult to adjust conflicting interests because the unit is too small. So strengthening equity and solidarity is important. National government should only indicate the fundamental principles and leave implementation up to the prefectures. This will lead to the vitalization of prefectural local autonomy. Healthcare rarely becomes a key election issue at the national level. Rather than that, privatization of postal services and fiscal reconsolidation and diplomacy issues become the election issues at the national level. If healthcare policy is delegated to the prefectural level, on the other hand, then it could become a key issue at gubernatorial or local assembly elections. If residents favor improvement in the healthcare systems, premiums can be increased, and the priority areas for improvement can be designated, such as cancer emergency service or rehabilitation, and those can be a key issue at elections at the prefectural level. So what are the various tasks involved in conducting such reform? First of all, the decision by national leaders is necessary. Chairman of the Policy Coordination Committee and Research Committee, Maihara, has left, but 90 years ago, as I mentioned in the morning session, the Health Insurance Act was implemented. Nobody at that time supported the act. the employers and the employees who are beneficiaries and physicians all strongly resisted. But overriding such resistance, the Health Insurance Act was implemented under the strong determination of the national leaders at the time. Another point is to develop human resources to plan and implement health policies. Currently, the human resources are concentrated under the Ministry of Health, Labor and Welfare. There is a need for teachers and training systems to develop human resources. And construction of database to validate health policy decisions is necessary. Without evidence, it is very difficult to convince the public of the need to raise premium. And the implementation of a common ID number system for all citizens is useful for assessing quality of healthcare from the patient's viewpoint, as well as for keeping track of income and benefits received. Next slide. So most important is to set the guiding principles of reform. Japan conventionally has been implementing gradual reforms, and this resulted in strong autonomy in the universities to develop any field of medical subspecialization. And the biennial revision of fee schedule has led to a fight for resources. There is fragmentation into 3,500 insurance plans, and there is expanding disparity among them. So without innovative reform, just conducting the current gradual slow reform is not sustainable for the universal coverage. There will be expansion in the number of uninsured and the risk of cutting back coverage by health insurances. And we are not able to develop emergency systems and advanced cancer treatment that is required. So there is a need to indicate a new vision of healthcare together with the recovery measures following the March 11 disaster. So the implementation should be done step by step, but target vision should be made clear. So these are the principles that I would like to propose to you.
ありがとうございました。
Thank you very much. Talking about the healthcare reform, according to my experience, 20-some years ago began the reform efforts by the governments. But it was mainly the reform for the funding sources. When I discussed the matter with the parliamentarians, I insisted that it should be the improvement for the medical healthcare delivery system. Professor Ike spoke from the human resources development. I wholeheartedly agree with you. And now we will have 3 commentators, and we will receive comments from them. As Professor Ikegami mentioned, the health reform or health insurance reform included municipalities, prefectural governments' roles are of extreme importance. So in that regard, we have Mr. Yamada, governor of Kyoto Prefecture. From this year, he serves as the president of National Governors Association. And it was an election, and it was rather rare, but the election was held, and he won in that position of the president of National Governors Association. So I will first ask Mr. Yamada for his comment. Governor Yamada, please.
よろしくお願いいたします。Thank you very much for giving me the floor. Professor Ikegami talked about the need for the government, national government, to show a vision for major reform, for such reform to be implemented. I completely agree. And in that context, prefectures have different roles to play from conventional roles. As has already been mentioned, the national government sets forth the plan and system, and prefectures implemented so far. However, I would wish to assert 2 points as necessary changes in the future. It's no longer possible for this system to be sustainable. There's too much disparity between the villages and towns, and universal for insurance system can no longer be sustained by leaving it up to the municipalities to implement. Another point. Now, prefecture isn't given the authority to decide upon the healthcare plans, and therefore there has to be a wider area in order to make the most appropriate plan for each region to provide for the best healthcare policy, and authority has to be given to the prefectures to do the planning and implement the plan, and the role of the prefectures should be reviewed. I'm currently, as introduced, the head of the National Governors Association, but I have the support of a third of the membership of this association, and from that context, I would like to explain my views. First of all, the very difficult challenge faced by the community-based citizens insurance system. Now, in the 1960s, basically, this system was for farmers, fishermen, and self-employed, or those running shops, and they accounted for 2/3 of the enrollees. In other words, in order to provide for insurance for those who didn't belong to large companies, this system was introduced, but it's become completely different in terms of nature. Now, if we look at the membership in 2009, 39.6 were unemployed and irregular employees who are very vulnerable position accounted for 35.2%. In other words, these two categories accounted for 3/4, 74.8%. They're not to the level of being provided livelihood benefits, but the community-based citizen health insurance is providing coverage for all of these people. And low-income households account for as high as 27%, which is threefold the percentage they accounted for in 76 of 8%. And also the income level of those insured by municipalities is half the large company employees. And therefore, universal insurance is being sustained by the payout by municipalities. And this is a major burden for the municipalities. And the burden will only increase in the future as the community ages. And therefore, this universal system is no longer sustainable, and therefore non-statutory allocation from general reserves and the use of reserves from the previous fiscal year has to be tapped upon in order to make the balance meet. The Ministry of Health, Labor and Welfare has issued notices to the municipalities to stop doing this, but they just say stop it, but they don't come up with a replacement measure. The number of patients who are only relying on the medical institutions within their municipality is less than half. And therefore, I am for the prefecture pooling the insurance plans, but I think there are too many loopholes in the plan proposed by the national government. First of all, the national government is proposing abolition of the elderly health insurance for 75 and above, and they're suggesting that the others that cannot be covered by employee-based plans should be covered by citizens' health insurance, and the employees and their dependents to be covered under employee-based plans. But this will invite the inequality in premium and inequality amongst the elderlies for 75 and above. And if this new gap is going to emerge, that is going to be a very serious problem. And this will once again invite unfairness amongst the elderlies. And they're suggesting that municipalities' only role is to collect premiums and then pay out all of the collected premiums to the prefecture. However, when this system is introduced, there will be one entity, the prefecture, in charge of the budgeting and balancing, and the municipality is only responsible for collection, so there would be no incentive. And also, because the fiscal situation is tight already, we may end up just having the debt burden be replaced to municipalities. National health insurance is a national minimum, and when we think that many of the subscribers are at the bottom of the pyramid, once again, we need to look at the system as a whole, or else this system is no longer sustainable. So based upon those problems that I've identified, the next is my suggestion in order to restructure towards a secure society. Professor Ikegami talked about human resources development, not just institution and insurance system, but in the end, we think that prefectures also should be incentivized for human resources development. The national government can come up with major framework or regime, but unfortunately the national government is without any implementation capability, and that lies at the municipality level. Kyoto Prefecture has prefectural universities, and every year we inject 8 billion yen of tax revenues to support such university. It's been there for 100 years, so already 800 billion yen, although that does not count inflation, has been invested for nurturing nurses and physicians at the medical university run by the prefecture. If we had invested the same amount on highways, we would have ended up with better roads, but without having done so, we were able to sustain a high quality of physicians and nurses because that investment was made. But the national government is saying place a ceiling on the number of physicians per prefecture, so restriction is the only thing the national government is thinking about. So these policies set forth by the national government will run into a corner if they don't think about what best human resource development could do. And also, the network of primary care providers and specialty physicians will have to be provided. This is a crucial problem. Mr. Maihara made a comment at the very outset that there are many who die in hospitals, but in fact, many people want to pass away at home. But when they are hospitalized, and if they are discharged, they worry that they will no longer be accepted by the hospital in need, or when they're in a nursing care home, they are concerned that if they are once released, that they would not be able to enter into a nursing home once again because of the long waiting list. So they think that this is a vested right that they need to protect. So many people hesitate being released from hospitals. So we need, for example, a hospital registration system so that most of the care could be provided at home. And also, ICT should be used for disease prevention and improved health maintenance system by making use of a society security and tax identification number system. And this is indispensable. With that, I would like to conclude my comment. Thank you.
Thank you very much to Governor Yamada. As you said, from the prefecture, you talked about the actual situation you faced in the local government. The second commentator, I would like to call upon Professor Shigeru Omi, a professor of Chichi Medical University. He is well known. He is professor of Division of General Practice Center of Chichi Medical University. Formerly, he was the Secretary General of the Asia Office of WHO, so he is a specialist in global health. Professor Omi, please. Thank you very much for the kind introduction. My name is Omi. Professor Kirami and Professor Watanabe mentioned that reform is necessary. And this is to reform or adjustment of premium revenue versus benefit. And it's not to do with drastic reform of service provision. Of course, in the assessment of WHO, Japan is an excellent student, as was mentioned by Professor Ikegami. The fee schedule system was effective to a certain extent, and because there was fine-tuning that was possible, up until today, the healthcare delivery system was never a topic full scale when thinking about future needs. Well, Professor Ikegami showed us various slides, wonderful, and the most impressive was the final slide shown by Professor Ikegami. He said that together with the efforts of reconstruction in the affected region, we need to indicate a new vision of healthcare. I totally support such statement. And there were two aspects mentioned by Professor Ikegami. One is to do with the financing. The integration of the insurance plan at the prefectural level. The other is to do with healthcare delivery. Today, I would like to focus on healthcare delivery only. So within the delivery system, Professor Ikegami, of course, pointed out various points. He especially alluded to two sets of issues. One, I think, was mentioned on page 4 of his slide. In accordance to the people's needs, the subspecialty or regional placement of necessary specialist physicians is necessary. That is what he made. That is what he said. And in the following slide, he also said that we have the so-called freedom to open practice system, and now we need to revisit the legitimacy of such a system at this time. And the second awareness of the issue, I think, is very important. In other words, the physicians are trained as specialists in specific organs. Of course, that is important expertise, but if that is the only training given, and if a general practice, of course, we can call it in any way. We can call it a general practice. We can call it family practice. But we have lacked training in that area of medicine. And I have a number of slides I would like to show you to talk about this topic. The blue portion shows the nationwide number of physicians in comparison to OECD numbers. We often talk about the number of physicians in Japan, but in absolute number, you see the blue curve. There's an increase in the number of physicians. The red is the affected areas of the disaster. This is an example from Iwate Prefecture. Overall, in Iwate Prefecture, as you see, there's an increase in the number of physicians. The next slide, in more detail, or shall we say in a specific locality. Kamaishi city has been hit, but inland there is the Senmaya hospital located, and if you focus on that locality, the blue is the population. Population, as you see, is declining, but the red line graph, the bar graph, 200 beds are installed in Senmai Hospital, and in 2001 there were 18 physicians overall. But immediately before the disaster, it has declined already to 5. So every year there's a decline of 1 physician per annum. So 18 minus 5, I'm not good in mathematics, but 13. Where did they go? So these 13 physicians, as was mentioned by someone previously, these are people who are specialists in specific organs. These are motivated physicians, but with a hospital of 200 beds, they have to do the night rounds alone, and there are various emergency patients that come, maybe fever, children, and people with abdominal pain, various symptoms and illnesses have to be attended to. And if the physician is trained only in a certain limited subspecialty, it is a big challenge for them. in Iwate Prefecture, it's not seen, but if there has been a misdiagnosis, there's also big concern that they will be litigated, and so that is why they retired. So who are the remaining 5 physicians in the hospital? Still in Japan, we're not seeing many of them, but after graduation from university, they not only go to their specific subspecialty, but they have undergone specific training to become general practitioners, primary care physicians, and they are preventing the collapse of the local healthcare system. Professor Ikegame repeatedly talked about this point. We have the universal coverage system, and so it is a mutual aid-based system. Everybody pays in out of their own means in order to support themselves. This is like the power charges. In the case of electricity, of course, wherever you live, there's the minimum level of power service provided. But in the case of healthcare service, there's 100% freedom of choice by physicians. So physicians will evade where they don't want to stay. And there are people, residents, who pay high level of premium rates. But despite that, there's a shortage of physicians. In a civilized country, this is not acceptable, but that is reality. So there's an imbalance of distribution of physicians. There are various ways to overcome that. As Professor Ikegami said, we need to take radical steps, but there are various steps available. One is to make mandatory, and the other is to take measures by the professionals themselves, and the other is to provide financial incentive. My personal proposal is that against the Japanese cultural backdrop, the professional organization together with the demand of the people needs to overcome these issues. And most important to do that is to have a good mindset of the physicians. Training of physicians is core to that and central to that. This is my personal opinion. This is what I propose to enhance quality of specialists. And along with that, we should set the target number of physicians in specific subspecialties. This is just my personal opinion, so I hope this serves as a point of discussion later on. But we have the clinical training after graduating from medical school. There's a 2-year program in Japan. So postgraduate clinical training, all physicians completing that training are receiving training currently, including internal medicine and surgery, and 18 basic areas of subspecialty. And so on top of that, they need to undergo primary care and general practice education as a 19th area of basic specialty. That is what I propose. And also the training program for the 19 area of basic specialty. The number of admission to training program has to be decided by someone. The biggest issue in Japan was that there was no governance. Nobody took responsibility to decide such things. And I think the neutral third-party organization at the central level needs to be set up, and also at the prefectural level needs to be set up to decide this. And looking at the European situation, comparing it to the Japanese situation, I propose that generalists should compose approximately 20 to 30% of all clinicians. When I mean generalists, the general practice should be considered one independent subspecialty, and we should call them all accredited physicians. And Professor Ikegami said that the grand design should be drawn up, but when it comes to implementation, that should be done step by step. So the system operation should be flexible and implemented step by step. I talked about neutral third-party organization. Professor Ikegami said that the Specialist Doctor Accreditation Association and the government